Welcome to the deep dive. Today, we're going to get into something pretty common, a health issue that affects a lot of our canine companions, canine cervical disc disease.
Yeah, it's basically like a slip disc, but, in the neck area.
Exactly. And lots of you listening might have dealt with this or maybe know someone whose dog has. So we really want to break it down today.
We're using canine cervical disc disease as our main source. It's a really solid overview of the condition.
It is. And our aim here is to sort of cut through the dense medical language and just pull out the key things you need to know.
Right. What it is, why it happens.
How to spot it, and crucially, what the options are to help. We want to give you practical info without it being overwhelming.
Okay, let's jump in.
So what are we actually talking about here? The basics.
So, at its core, it's about the discs between the neck bones, the vertebrae. These discs are like little cushions.
Okay.
And in this disease, they start to degenerate, to break down.
And then what happens?
Well, that breakdown means the inner, softer part of the disc can bulge out, or sometimes even properly rupture,
Uh-huh.
and that material pushes into the spinal canal, where the spinal cord runs.
Ouch. Okay, so that displaced stuff causes problems. What kind of problem?
Exactly. It can press directly on the spinal cord itself. We call that myelopathy.
Myelopathy, got it.
Or it can squeeze the nerve roots that branch off the spinal cord, right where they exit. And that's called radiculopathy.
Radiculopathy, so pressure on the main cord or the branches coming off it.
Yeah, think of it like stepping on a garden hose.
Mm.
It disrupts the flow. In this case, nerve signals.
Right. Now, the source mentions two main ways this degeneration happens. Can you take us through those?
Sure. The first one is Hansen type I. This is usually quite sudden. An acute herniation.
Acute, meaning fast.
Yeah, pretty sudden onset. What happens is the center of the disc, the nucleus pulposus, it undergoes what's called chondroid degeneration. It gets sort of dry, brittle, almost cartilage-like. Then the outer ring of the disc, the annulus fibrosus, it tears. And that brittle center stuff just squeezes out into the spinal canal.
Wow, sounds dramatic. Are certain dogs more prone to this type I?
Oh, definitely. Hansen type I is classic in chondrodystrophoid breeds.
Okay, those are their...
The dogs with the shorter legs and often longer backs. Think dachshunds, beagles, cocker spaniels.
Ah, right, those guys.
Yeah. And it typically hits them when they're younger, usually around 3 to 6 years old.
Okay, so type I, sudden brittle rupture, younger dogs, specific breeds. What's the second type?
The second one is Hansen type 2. This is more of a chronic, gradual thing, a disc protrusion rather than an extrusion.
Slower then.
Much slower. Here, the disc center goes through a different change, fibrinoid degeneration. It doesn't rupture suddenly. Instead, the outer layer, especially the top part, just gradually bulges or protrudes outwards, pushing into the spinal canal over time.
And who gets this type 2 more often?
This one's more common in larger breeds, like Dobermans are a classic example.
Oh.
And it tends to happen in older dogs, say 8 to 10 years old, typically.
So different breeds, different ages, different speeds, but the end result is still pressure in that spinal canal area.
Exactly. Both types, whether it's the sudden extrusion or the slow protrusion, end up causing compression, focal compression, usually, on the spinal cord or the nerve roots or both.
And that compression leads to...
It can cause ischemia, lack of blood flow to the nervous tissue, and demyelination, which is damage to the protective sheath around the nerves, so they don't conduct signals properly.
Interesting. The source also mentioned something about dorsal protrusion being common.
Yeah, meaning the disc material tends to push upwards towards the roof of the spinal canal more often than sideways. It can go sideways, but dorsal is more typical.
Okay. And what about this domino effect with surgery?
Yeah. So sometimes surgery involves fusing vertebrae together to stabilize the problem area.
Right.
But when you fuse one segment, it can change the forces on the discs next door, the adjacent ones.
Makes sense.
And sometimes that extra stress can make those neighboring discs more likely to develop problems later on. It's something to be aware of.
Definitely. Okay, so let's talk risk factors again. We know breed is huge.
Yeah.
Just how big a factor is it?
It's really significant. Like we said, those chondrodystrophoid breeds for type I. If you look at the numbers, cervical disc disease overall is maybe 15% of all disc issues in dogs.
Okay.
But get this, dachshunds, beagles, and poodles together account for something like 80% of the extrusions, the type I ruptures.
80%. Wow.
Yeah. And while maybe 2% of all dogs might get some form of disc disease in their life, for dachshunds, that risk jumps way up to around 25%.
1 in 4 dachshunds. That's huge. Owners really need to know that.
Absolutely.
Is there a specific spot in the neck that gets hit most often?
Yes, the C3, C4 disc space, sort of mid-neck, seems to be the most common location reported.
C3, C4, okay. And besides breed, are there other things that might increase the risk?
Well, genetics is the main driver. But things like obesity, extra weight, putting strain on the spine, and maybe repeated minor trauma, or certain activities, especially in those predisposed breeds, are thought to potentially contribute.
So keeping our dogs, especially those Dachshunds and Beagles, at a healthy weight is probably a really good idea.
Definitely good preventative measure, yes.
All right, let's shift to what owners really need to know. How do you spot this? What are the signs we should look out for?
The number one complaint owners usually have is neck pain. That's the big one.
Just a pain. How does that show up?
Your dog might yelp when picked up, or maybe they're just reluctant to turn their head. They might hold their head low, kind of hunched.
Okay.
You might also see a stiff gait, like they're walking very carefully, or muscle spasms, especially around the neck and shoulders.
That sounds uncomfortable. Are there more serious signs?
Yes, definitely. In maybe 10% of cases, dogs can become tetraplegic, weakness in all four legs. They might be wobbly or struggle to support their weight. You could also see muscle wasting, atrophy, particularly over the shoulder blades, if it's been going on a while.
That sounds much more severe. What about that root signature thing you mentioned? Radiculopathy, what does that look like?
Right, the root signature, that's typically neck pain plus lameness in one of the front legs, like they're holding a front paw up or limping badly on it.
Ah, okay.
It happens when the disc herniates out sideways, dorsolaterally, and pinches a specific nerve root going down that leg. Seeing that combo neck pain and front leg lameness often points towards a problem lower down in the neck, maybe C4 to C7.
So limping and a sore neck together, big red flag. What would my vet look for in an exam?
They'll carefully feel the neck muscles, looking for spasms or pain reactions. They'll also gently manipulate the neck, bending it up, down, side to side to see if that causes pain.
Okay.
Sometimes just pressing deeply along the neck can elicit a response. There's also something called the wheelbarrow reflex test. They briefly lift the dog's back legs, so they're supporting weight only on the front. Neck pain can make them stumble or drop their head, maybe even hit their nose. But it's important to know sometimes the neurological signs can be quite subtle at first, especially with neck issues. The spinal canal is a bit wider there compared to the back.
So they might be in significant pain without obvious weakness initially.
Exactly. Pain is a really key indicator, even if other neurological signs seem mild. But the vet will also check for paresis weakness in all limbs. Interestingly, the back legs can sometimes seem weaker than the front.
Okay. And reflexes.
Yeah, they'll check reflexes in the legs. They could be normal, exaggerated, or even decreased, depending on where the compression is hitting the spinal cord pathways.
And the source stressed this, which seems important. The severity of the outward signs doesn't always perfectly match how bad the compression looks on imaging.
That's a crucial point. You can have severe compression with relatively mild signs, or vice versa sometimes. And things like bladder control can vary too. Sometimes it's affected, sometimes not.
Okay, quite a range of possibilities. Let's quickly recap the causes. Type 1.
Type I is that early chondroid degeneration. The disc center gets brittle, calcifies, and then ruptures through a tear in the outer layer.
And type 2?
Type 2 is the slower fibroid degeneration, leading to a gradual bulging or protrusion of the disc without that acute rupture.
Got it. Brittle rupture versus slow bulge. So if the vet suspects this, what's the diagnostic process like? What tests are involved?
Well, often they'll start with some baseline tests, especially for older dogs or if surgery is being considered. Things like a CBC blood count, biochemistry panel, and a urinalysis, just to check overall health.
Standard stuff. What about more specific tests?
CSF analysis can be helpful. That's cerebrospinal fluid, the fluid around the brain and spine,
How do they get that?
usually via cisternal tap, a needle carefully inserted at the base of the skull into the fluid space.
Okay. And what does that tell them?
In disc disease, you often see mild to moderate increases in protein and sometimes cells in the CSF. It tends to be a bit more pronounced with the acute type I herniations. EMG, electromyography, might also be used to look for nerve damage.
But the real key is imaging, right?
Absolutely. Imaging is critical. Cervical spinal x-rays are usually the first step, done under anesthesia so the dog is perfectly still.
What can you see on an x-ray?
Sometimes you can see signs like a narrow disc space, maybe the space looks wedge-shaped, or changes in the little joints between vertebrae. You might even see calcified disc material in the canal, or where the nerves exit. With type 2, you might see bony spurs, spondylosis.
So x-rays give clues, but don't always show the disc itself pressing on things.
Exactly. X-rays are great for bones, less so for soft tissues like discs in the spinal cord. They also help rule out other things like fractures or tumors.
So if x-rays aren't conclusive,
Then myelography is often the next step. It's
Yeah.
needed in like 90–95% of cases to really see the compression.
myelography, that involves dye.
Yes. A contrast dye is injected into the spinal fluid space, usually via a lumbar puncture in the lower back. Then more x-rays are taken. The dye outlines the spinal cord.
Ah, so you can see where the disc is pushing in.
Precisely. You'll see the dye column deviate or get narrowed where the compression is. Special angled oblique views help see herniations off to the side.
Any catches with myelography?
Well, if there's a really acute rupture with lots of swelling around the cord, sometimes the swelling itself can block the dye flow, making it hard to see past that point.
Okay. What about the more advanced stuff, MRI and CT?
Yeah, MRI and CT are fantastic tools here. They're especially useful if the herniation is way off to the side, in the foramen where the nerve exits, or even a myelogram might look normal.
Which is better, MRI or CT?
MRI is generally considered the gold standard. It's excellent for seeing the soft tissues, the disc itself, early degeneration, the spinal cord, any swelling, and showing direct nerve root compression really well. CT is also very useful, especially good at showing bony detail in calcified material, and it can sometimes help if contrast flow was blocked on a myelogram.
So a whole toolkit for diagnosis. Once they know what's going on, what do they actually find? Like, what does the damaged disc or spinal cord look like?
Well, grossly, meaning what you see with the naked eye during surgery or an autopsy, it differs. Type I extruded material is often whitish, kind of granular, and usually you can remove it fairly easily.
Okay.
Type 2 protrusions are different. They're firmer. It's the bulging outer disc layer, and it's often stuck quite firmly to the floor of the spinal canal and the dura, the covering of the cord. Much harder to dissect free.
And the spinal cord itself?
In acute type I cases, the cord might look bruised or swollen. In chronic type 2, it might look a bit shrunken, atrophied, or sometimes surprisingly normal on the surface.
What about under the microscope, histopathology?
Microscopically, you see distinct changes. Type I discs lose water, and certain proteins, collagen increases. It basically turns cartilage-like, often with calcium deposit.
Right, that chondroid change?
Exactly. Type 2 discs show more fibroid changes, different protein levels, less collagen increase, and crucially, no cartilage metaplasia in the nucleus.
And the cord tissue itself.
With type 2, you might see that demyelination, damage to the nerve coating, and gliosis, which is like scarring in the nervous system. With acute type I, you're more likely to see hemorrhage, edema, or swelling. And in really severe type I cases, you can get myelomalacia, which is softening, and death of the spinal cord tissue itself.
Wow, okay, so clear differences reflecting the different processes. Now, the really important part, recovery. What are the treatment options?
It really hinges on the severity and how quickly signs appeared. For dogs with milder signs, maybe just neck pain, slight wobbliness, gradual onset conservative management might be tried first.
And what does conservative involve?
The absolute cornerstone is strict cage rest, really strict, for about 3 to 4 weeks.
Cage rest, no running around.
Done. Only out for toilet breaks, on a leash, and crucially, using a harness, not a neck collar.
Harness, not collar. Got it.
And if the dog's overweight, weight loss is definitely part of the plan.
So rest, harness, weight management for mild cases. When is surgery considered?
Surgery is usually recommended if a dog has recurrent episodes or if they present with severe pain, along with neurological deficits like weakness,
Okay.
or if they just don't get better with that strict conservative rest.
And what's the goal of surgery?
Decompression. To physically remove the disc material that's pressing on the spinal cord or nerve roots.
How do they do that in the neck?
The most common approach is called a ventral slot. The surgeon goes in from underneath the neck, makes a small window or slot in the vertebral bodies, and removes the disc material through that opening. If the herniation is more to the side or top, they might use a different approach, like a lateral one or a dorsal laminectomy, removing a bit of bone from the top. Fenestration, just making a hole in the disc, isn't generally recommended on its own for neck issues, as it doesn't really decompress the cord.
Right, you need to get the pressure off. What about aftercare, whether it's rest or surgery?
Nursing care is huge. You want to minimize any neck manipulation. Try to avoid jugular blood draws if possible.
Makes sense.
Monitor urination and defecation closely. Sometimes they need help, like having their bladder expressed. For dogs that can't walk, preventing bed sores is vital soft bedding, turning them every few hours.
And activity.
Very restricted initially. Even after surgery, it's typically just short, slow leash walks with that harness for maybe 4 to 6 weeks, that a very gradual return to more activity. Physical therapy can also be really beneficial, things like passive range of motion exercises, hydrotherapy.
What about medications? Do they play a role?
Yes, they can. For conservative management, sometimes low-dose corticosteroids are used for pain and inflammation, but only with strict rest. That rest is non-negotiable.
Okay.
NSAIDs, non-steroidal anti-inflammatories, are another option for pain. But, and this is critical, you never use corticosteroids and NSAIDs together. The risk of stomach ulcers is just too high.
Right, one or the other, not both.
Exactly. Muscle relaxants are sometimes tried, but often aren't very effective by themselves. And if high-dose steroids are used, which isn't generally the first choice anymore, gastroprotectant drugs might be added, but again, used cautiously.
So meds are supportive, used carefully alongside rest or surgery. What's the outlook? The prognosis?
It really depends heavily on the neurological status at presentation. How bad were the signs when the dog came in? Overall, for many dogs, especially those with just pain or mild deficits, the prognosis is generally favorable.
That's good to hear.
However, with conservative management alone, there is a risk of recurrence. The problem can come back, sometimes worse, and might end up needing surgery down the line anyway.
And what about those severe cases? You mentioned something critical about timing.
Yes, this is vital. For dogs that have lost deep pain sensation in their limbs, that's a very serious sign. Time is absolutely critical for surgery.
How critical?
The data suggests that if surgery is performed within about 12 hours of losing deep pain, the recovery rate is around 56%. Still not guaranteed, but decent odds.
Okay. And if you wait longer?
If surgery is delayed beyond 48 hours after losing deep pain, the chance of recovery plummets to less than 5%.
Wow. Less than 5% after 2 days. That really underscores the emergency nature of those severe cases.
It really does. Faster is definitely better when deep pain is lost.
Okay. Lastly, prevention. Is there anything we can actually do to prevent this?
Well, given the strong genetic link in certain breeds, you can't entirely prevent the predisposition.
Right, can't change their genes.
But the most practical thing owners can do is maintain an ideal body weight. Less weight means less stress on all the joints, including those intervertebral discs.
Keep them lean, especially the high-risk breeds.
Exactly.
Okay, well, this has been incredibly informative. A real deep dive. So to quickly recap, 2 main types. Hansen-Aber, sudden, brittle, often Dachshund Spiegels, and Hansen-Sechet, slow bulge, often older large breeds.
Neck pain is the most common sign, but look out for weakness, lameness, muscle spasms too. Diagnosis involves exams, often x-rays, and usually advanced imaging like myelography, CT, or MRI to see the compression.
Treatment is either strict rest or surgery for decompression, depending on severity. And for severe cases losing deep pain, getting to surgery ASAP is absolutely crucial for the prognosis.
Hopefully you feel you've got a much better handle on this condition now, making you a more informed owner or animal professional.
Definitely. Which brings us to a final thought. Given those really strong breed predispositions we talked about, particularly for type I, it does make you think about breeding practices, doesn't it?
It certainly raises questions about breeding for specific conformations that carry these inherent health risks.
Or, looking ahead with imaging getting better and better, maybe we'll see advances in earlier detection or even less invasive ways to intervene before things get really severe.
That's definitely a possibility to watch in veterinary medicine. Lots to think about.
Indeed. Well, thanks for joining us for this deep dive today.